Thank you, Jessica. That paper is certainly one that we very much like talking about because these are very powerful impacts, and it will be good to understand how to do it better and how to have these kinds of interventions in other contexts as well. But to move on from agriculture as a subject dear to everyone's heart to another one that everyone cares about very much in the development sector, healthcare. Right? So this is a paper that I'm presenting for two researchers who weren't able to join us today, Pascaline Dupas and Jonathan Robinson. You heard another one of their papers this morning. They have run a number of very interesting studies in Kenya, and this is one of them. And this study is about why don't the poor save more? And it's evidence from a number of variations in offering health savings products to the poor in Kenya. So I'll quickly run through why this intervention is interesting or why it was required. I'll say a little bit about the design of the experiment itself, and then the study setting, who are the people we're talking about, who are participating in the study, how did they implement the study, what did we learn, and of course, what do we take away from it. And just so you know where we're going with this entire discussion, what was tested was basically several ways of providing health savings products, but these variations were offered jointly in one experiment. And the idea was to see, does the characteristic of a savings product matter? And does it vary by the person who is adopting the product? And the result is it does matter. And it seems very obvious when you put it up here to say, yes, of course, people are different, they have different needs. But you'll be surprised at how even when I go to get a home loan, the bank officer is not at all interested in anything more than some very basic financial figures and not about the flows of my income, my needs, my liabilities, my aspirations, none of it. Right? So this is interesting to keep in mind as we think about our own experience with the financial sector. So some motivation, I'll just very quickly skim through this because all the projects say the same data, that's why. So, but there's very low levels of access and usage of formal financial services. And these are just some numbers. There are some estimates that in sub-Saharan Africa, only 15% of households have a bank account, and that itself some would say is an optimistic estimate. And in a series of studies that we have ongoing in a number of African countries, and Brown will talk about some of these, in these sort of large sample studies, so about 5,000 to 6,000 households surveyed, primarily in rural areas, for women's use of access to formal bank accounts is less than 4% in these samples. So that's amazing. That's basically that nobody is using a bank account, and for Kenya it's a little higher, less than 10% from a study which had over 2,000 households. But there is this overwhelming evidence, not overwhelming, there is evidence right now that suggests that there can be quite serious welfare impacts from using savings accounts. So, and this is just access to savings accounts, right? So we have a couple of studies which talk about consumption expenditures, we heard about this study in the morning, and business investment. There is another study from Nepal which talks about asset building, like wealth increasing as a result of access to savings accounts, very basic savings accounts, and education and health investment. So clearly expanding access is beneficial, but what kinds of products should we be expanding access to? Here we come to some interesting discussions around what kinds of features are important or interesting to the poor. So there's some questions around liquidity features, right? And the discussion this morning that Simone led was very interesting. How liquid should a bank account be for it to be useful for different kinds of people for different requirements? Commitment features, we just heard about this, when Jessica was talking about her project in Malawi. Reminders as a feature on a bank account, that's for tomorrow. Default settings we won't discuss here, but this is very much what you do with your retirement savings. One day you have signed up to say, please take away X% of my income every month and put it away, and I don't want to look at it until I am quite old. And the reason it works is because after that you don't even think about it. Automatically every month I'm accumulating the saving, and it's because of inertia that I don't change it, thankfully, and at the end of the day I'm better off for it. Another very powerful sort of behavioral theory comes from Richard Taylor, and this is what Jessica mentioned towards the end. This idea that people, when they're thinking about their resources or their funds, money is fungible, right? I can use the same money for zillions of things. But somehow in our minds, we allocate money to different kinds of money. I say this is my money for education, this is my money for petrol, and this is my other bucket of money which is for beer and other things, and hopefully it's very small, right? So we have different ways of allocating things in our minds, and this sort of phenomenon he calls mental accounting. And this experiment rides on exploring what is it that happens when people use mental accounting to achieve their goals. So the core sector we're concerned with here is healthcare. Why do people, the broad question is, why are people taking up savings accounts? Clearly it's not just to accumulate money, because money really doesn't mean anything unless it's used for something useful. So then how can informal products that help people save work towards improving healthcare outcomes? Yeah? So why does providing savings accounts help, and how can this saving lead to better health outcomes? And this is not necessarily just relevant for healthcare. It could be any goal, any strong goal that motivates people to set something aside for the future. So the experiment is with trying different informal savings products. And this is a question we should discuss maybe as well and hear comments on. There's this wide continuum, right, of formal and informal savings products. And it's interesting to look at what features work best in the informal space that should be adapted towards more formal products, and vice versa. What is it about security and dealing with risk that is good about the formal sector that needs to sort of spread into the way informal products and services are designed to use? But this experiment is primarily with informal savings products. They're all healthcare savings products, but their characteristics differ. And what they were looking at the end of the day were how many people take up the account when they are offered this account, how do they use it, and how does this translate into expenditures on health? And this is the key outcome that they're interested in. Not just savings balances, but what happens to how much I'm spending on health. And also sort of how susceptible am I to risks from sort of healthcare shocks. So where this was implemented was in Western Kenya, where they do a lot of their work. And it was in one administrative division where they conducted a census of all of the ROSCAs in the region. So the rotating savings and credit associations are common knowledge here. It's very popular. Around, I think, over 40% of adults in their study area were participating in ROSCAs. And I think this is also quite low compared to other areas. And so at the end of the day, they had about 113 ROSCAs who were participating in their study, about 2,000 people. And of these, all of them participated in the study, but they randomly sampled about 771 of them for their survey work. So it was everybody received the treatment, but 770 people were the respondents in the study. And these ROSCAs were offered different kinds of savings products, and they were in order to meet two different kinds of health savings goals. One is around preventative health expenditures, right? So these are the kinds of things that we do to prevent ourselves from falling sick. And in this region, this takes the form of expenditures like bed nets to stop malaria, water filters in order to reduce the likelihood of getting waterborne diseases like diarrhea, etc. And on the other hand, you have other kinds of health expenditure requirements that are around emergencies. So somebody, either falls sick, falls down, has an accident. How am I going to fund that fairly big lump sum expenditure? So two different kinds of healthcare expenses and requirements. So how do we approach them? How do we build up savings towards these goals? And why, I think in all of this, a key question to ask is, why is this not happening automatically? Clearly, I see myself falling sick. Clearly, I see my family falling sick. And I know it happens at some regular interval, right? So why is it that I can't just set aside some money or make some arrangements to deal with it when it comes up? And part of it has to do with interpersonal obligations and issues that we all deal with, right? So whether it's relatives, friends, neighbors, who need cash at different points in time. And it's very difficult to say no because you know that they have a real need. But it could also be within the household, with your own, parents, spouses, your children. These are also difficult sort of negotiations sometimes about what's the optimal use of money, how do you set it aside for an event in the future. And the second set of barriers have to do with what we've been discussing here. They are inside of the mind. They are my own issues as a person. How easy is it for me to make a commitment towards a certain goal, stick with the plan? How often do I get distracted? All of these are vary quite widely in the population, right? So there are three mechanisms being tested here. And this study, if at some point you get lost, please raise your hand, because there are many treatment conditions, or we'll discuss it further in the discussion period. But there are three big things being tested. First, so what happens if I just help you overcome the barrier of having a safe place to store your money? Simple, yeah? With an informal savings program. Second, what if I allow you to save your money safely, store it safely, but I also allow you to tag it as healthcare? So that's the earmarking feature, right? That's a commitment feature. Say this is only for health expenses. And over and above that, maybe I can also try something to say, yes, I've committed to, I put a label on this that says it's going to be my healthcare expense pot. But then can I also make sure that other people around me enforce my putting money into the pot and keeping it there for healthcare expenses? And that's the social commitment and credit aspect. And the credit here is a little misleading, but in a ROSCA, everybody puts money in, but only one person gets the draw each time. So the person who gets it first is actually getting something in credit, right? Because they're getting an advance of fully paying the amount for the bed net, for example. But that's what it means, that, that's the treatment. So I just quickly walk through the treatment arms. So the safe box is the representation of just the safe storage mechanism. All it is a little box, and you'll see it. It's offered in the ROSCA meeting. Every individual gets one. You can keep your money in it at home. And it can be spent on anything ultimately, because in the safe box treatment, you have the key to your own safe box. So when you want to, you can open it up and spend it, but you are sort of, it's allowed, or you're taking it up mainly for healthcare expenses. And in this case, the P and the E refer to, this can be used for preventative expenses as well as for emergency expenses, right? Because it's liquid. I'm just setting it aside for healthcare, but I can use it for any kind of healthcare expense. Versus the lockbox, which is mainly for the preventative health product. Here, I'm committing to, save up for a bed net, for example. But then the key, I put money into the box, but the key is already given to the loan officer of the ROSCA, or the program officer associated with the ROSCA. And the only time I can open the box is when I need to use it to buy a bed net. Other than that, I'm not allowed to sort of open the box, right? And then the number of the program officer is listed. I can call them when I'm ready, and then I get my healthcare product. This is the box. So this is a little to say that this is not at all some far-flung object, so simple. But it'll be interesting to see how powerful something as simple as this can be when you don't have access to many services. The other two treatment arms were the health pot. This is adding the social commitment component. And here, basically, the entire ROSCA decides to have a common contribution for a healthcare product. And like I said, every person gets the healthcare product once a week. So it's also earmarking, but it's also a strong commitment device. You can't use the money for anything else. And finally, the health savings account, which is mainly for health emergencies. And this is an individual savings account that you can create at the ROSCA, put money into it. The ROSCA treasurer keeps it in the bank account. And when you have an emergency, when you need something for medication, you make the case in the ROSCA, and then you're able to access those funds from your individual account. Does that make sense? 113 groups, 20 ROSCAs allocated to safe box, 20 to the lockbox treatment, but I don't have the key, 23 to the health pot, another 26 to the health savings account, which is the individual emergency savings account, and another 18 to the control group. So what are we looking at? The safe box only looks at the effect of safe storage. Lockbox adds the measurement of earmarking to safe storage. HealthPot looks at social commitment on top of earmarking and safe storage. That's what you're getting out of that experimental arm. And the health savings account is only to be compared with the safe box, because those were the only two treatments that were dealing with emergency health expenditures. Yeah? This study was conducted between 2008 and 2009 initially. So you will see the timeline. There were 143 Roscas who were part of the census, 113 were part of the first baseline information session. The baseline survey was with 770 respondents. And then after 6 months, there was a midline survey. After 12 months, another endline survey. And they also interestingly followed up 3 years after the intervention to look at long-run impacts. Who are these people? Most ROSCA participants in this area, and maybe in other places as well, in this place they were women, 75%, and most of them were married, about 39 years of age, 4 children per person, about 6.3 years of education, so not primary school completed, about a quarter had a cement floor in their house, and their average weekly income was about $8. Healthcare baseline information, about 1.5 bed nets per household, even though they had about 5 people who would require it. About 34% of the children under 5 in these households had malaria in the previous month. 20% of those reporting also said they had malaria in the past month. And malaria broadly defined as strong fever to malaria, right? So I'm going to now talk about some of the results. First, about take-up of the product, right? What is amazing about this study is that informal savings products like this, all of us talk about ROSCAs being popular, but the take-up of these accounts was amazingly high compared to any other formal savings account study you will see. Maybe not mobile money, but close enough. So 71% after a year for SafeBox, and you will see between 66 and 97% take-up, which is very high, and even 3 years down, about 40 to 50% were still using these savings technologies. What do we learn in terms of impact on health? In the control group, they were spending about 257, this is at the end of 1 year, 257 shillings on preventative healthcare expenses. If you look at the SafeBox treatment, right, an increase to 427 Kenyan shillings. And this is significant at sort of the 10% level. The lockbox also increases investment, but the health bot, astounding result. You have something like, 120% increase in how much people are investing in preventative healthcare from a mechanism that combines all these three pathways of influencing behavior. And the health savings account, remember, that's the emergency savings account. Clearly, it didn't have an effect on preventative healthcare investments. So just to see the magnitude of these impacts are quite strong compared to where people are starting off. In terms of risk coping, right? How do people deal with emergencies? The inability to afford a medical treatment in the past 3 months was the outcome variable measured. The control group said 30% of them, 31%, were unable to afford a medical treatment in the past 3 months because of cash. Fewer in the SafeBox, fewer in the lockbox, but not as much as the SafeBox treatment's effect. But the one that stands out here is the health savings account. This is the individual account I've set aside for emergency expenses. And here you see only about 20%, about 19% of people report not being able to fund a medical expense in the past 3 months. And this is again significant compared to the baseline that we started off with. So I'll just briefly say there were other impacts. The study has looked very seriously at different kinds of people. So people with present bias, for example, benefited less from the SafeBox, and you can understand why, because it's very easily accessible. I don't really wait until the actual healthcare expenditure is required, but I use it for other things. Also, those who had larger families or more demands from their kin network, seem to have benefited more from the earmarking feature, where I'm committing the money away. And this also the savings for goals apparently expands to other goals in the 3-year follow-up, when people say, I'm also saving for business expenses and education. So these are sort of the takeaways from this study. From just the introduction of a very simple SafeBox, you're able to see a 66 to 75% increase in preventative healthcare expenditures or investments. And similarly, in the health pot treatment, when you add on the social commitment feature, this rises to about 128% increase. Earmarking definitely has a liquidity cost. So in the case of the preventative health expenditures or the preventative health products that were offered, when it was earmarked, people could not use that for emergencies, and that was a cost. But for emergency healthcare expenses, earmarking does help. And this nuance is extremely important for us to understand in how we design products. I think I will end with that, but I'd love for you to think a little bit more about mental accounting and how it can be used productively in all sorts of ways. And I'm sure we'll come back to this in the discussion. Thank you.